Hello everyone, I am Dr. Jigisha Pujara. Today I am going to speak about emerging and future application of Nirs. I am professor in Department of Cardiac Anesthesia in UNMICRC Institute of Cardiology and Research Center, Ahmedabad. Joboses in 1977 first described the non-invasive near-infrared spectroscopy, that is Nirs, to continuously measure tissue oxygen sufficiency in cephala. Commercialization of Nirs technology in 1990s led to the development of the tissue oximeters for clinical use that calculate and display real-time continuous cerebral, that is SCO2, and somatic, that is STO2, tissue oxygen saturation. Pediatric cardiac surgery was an early to adopt these Nirs for both research and the clinical application. Cerebral Nirs monitoring has been advocated as a surrogate measure of mixed venous oxygen saturation. Scientific basis of modified Beer-Lambert law, absorption of the material sample is directly proportional to the path of length and the concentration. Nirs is a non-invasive continuous method of evaluating regional tissue oxygen based on different absorption of varying wavelengths of the oxygenate and the deoxygenate hemoglobin. Nirs offers several advantages over the other neuromonitoring modalities like jugular bulb oximetry, transcranial Doppler sonography, electroencephalography, in that it is non-invasive, portable, provide continuous measurement, and with respect to commercial system, it is easy to use and relatively inexpensive. Technology, near-infrared light, say that is 700 to 1000 nanometer wavelength, is able to pass through the biological tissue so that the intensity of the emerging light can be measured. Light attenuation results from absorption by the oxygen-dependent chromosomes. These are oxyhemoglobin, HHB, deoxyhemoglobin, reduced hemoglobin, cytochrome C oxidase, myoglobin, etc. of various variable concentrations. Chromosomes of fixed concentration like melanin, water, collagen, lipids, and light scattering. Differential absorption spectra of the oxygen-dependent chromosome in the Nirs range permits spectroscopic separation and the measurement of the tissue oxygenation and blood flow. The Nirs methodology, continuous wave spectroscopy emits light at a constant intensity and measures the intensity of the light emerging from the tissue. FD, that is a frequency domain, time domain, and the DCS, that is diffuse correlation spectroscopy, are more advanced technology used predominantly for the research. Here you can see in the figure, first is continuous wave, here emits the constant light intensity and measures attenuation in the transmission light intensity. Second one is the frequency domain, emit the modulated light intensity and measures the phase shift attenuation in the transmission light intensity. And third one is a time domain, here emits the short pulse of the light and measures arrival time of the transmission photons, shape of the transmission pulse. Now the technique, optical electrodes called the optodes are applied on the skin of the forehead on this clean hair-free zone. Here these optodes have an infrared light emitting source and two photodetectors integrated into a self-adhesive rubber plate. The infrared light wavelengths between the 650 to 1350 nanometer emitted from the optodes passes through the skin, skull, and brain tissue, and the reflected beams are received by the photodetector within the same rubber plate of the optodes. Tissue oximeter use an optodes. These are sensors arranged such that the Nirs travel in a curvilinear or the banana shape path in the region beneath the sensor. Here you can see the cerebral tissue oximetry axial cross-section diagram of this specially resolved reflected mode spectroscopy. Near infrared light travel in a curvilinear banana shape path in the region beneath the sensor to interrogate unknown mixture of the small diameter like less than 100 nanometer gas exchanging vessels, arterioles, capillaries, and the venules. and in the underlying tissue, the depth of the penetration is approximately half the emitted detected distance. Clinical application of cerebral oximetry in the pediatric surgery. These are the aortic arch surgery with the deep hypothermic circulatory arrest, neonatal cyanotic heart disease, complex cardiac surgery for the truncus arteriosus, TGA, HLHs, etc. SCO2 in the PDA, high frequency ventilation, ECMO, ventricular assist device, liver transplantation, neonatal bowel ischemia, etc. Brain oximetry, what does it predict? It predicts airway, A for airway, for true hypoxia, B for breathing adequacy, C for circulatory monitor, D for diagnostic, and E for expectancy of the survival is a biomarker. Normative and the critical values for cerebral SCO2 in healthy children are 65% plus or minus 10%, and in infants 64 plus or minus 5%. In children with the CHD and adequately compensated chronic hypoxia, arterial oxygen saturation less than 90%, Cushman et al. Found SCO2 value of 69% plus or minus 6%. So more or less is not much less, rather it is slightly more with the deoxygenate child also, which is compensated. Now, SCO2 value of 33 to 45% increases brain lactate, decreases the EEG amplitude, EEG slowing, and the decrease in the tissue density, adenosine triphosphate level, cardiovascular collapse, blood lactate elevation, and metabolic acidosis, and marked histologic changes observed. These are the vacuolization, cell fragmentation, severe mitochondrial injury, etc. 45% to 60%. This is the best we have to act here. 45 to 60% is a buffer zone, whereby cerebral oxygenation is adequate for function but lower than the normal and necessitate the prompt re-evaluation of the patient, and we have to act. This is the buffer zone where we have to act. If it is less than that, then it is difficult to manage, but this period will give you time so that you can act and you can reverse the irreversible changes occur in the patient. For somatic in healthy newborns and preterm infants, average renal STO2 is 86.82 plus or minus 8.1% with a range of 64 to 70%. Probe placed above the iliac crest to assess the renal blood flow. Baseline abdominal infraumbilical STO2 range from 32% to 66% in the appropriately sized patient in nose probe placed on the anterior abdominal wall or below the level of the umbilicus can be used to monitor regional oxygenation of the superior mesenteric artery vascular bed. Important concept may be somatic cerebral difference STO2 to SCO2 and multiple NIRS. These are the modalities used for better evaluation. Here is the SCO2 driven management algorithm for the congenital heart surgery. Cerebral tissue oxygen saturation, that is SCO2, when less than 60%, downtrending, left to right difference more than 10%, not increasing with the cooling. When this is a scenario, first, ensure secure airway and adequate oxygenation. Verify monitor integrity. First, confirm the sensor placement. Ensure adequate skin contact. Limit the ambient light. Verify head position. Place head in the midline, neck neutral position. Limit the lateral rotation. And another third is confirm the adequate signal quality. After doing these, if we have to evaluate the cerebral DO2. So cerebral DO2 pre-CPB, post-CPB, ICU and cath lab, we have to modify with the increased FiO2 if appropriate, exclude the hypocapnia and optimize the arterial blood pressure and the flow of the blood, cardiac output. Consider fluid bolus, inotrop, vasopressors, or the vasodilator as the appropriate. And another modality to manage this type of the patient are correct the anemia as if a cyanotic patient less than 30% and cyanotic patient less than 40%, we should consider to treat the anemia in such type of the scenario by increasing the PRBC. On CPB management exclude the malposition of the aortic or the venous cannulation, and discuss with the surgeon if anything can be done for that. Evaluate the adequacy of the CPB, increase the PaO2, SaO2, check for these, and or SvO2. If they are low, increase the FiO2, increase the flow. Mean arterial pressure or the cerebral perfusion pressure if low, increase the flow, add the vasopressors if required, and improve in the hematocrit if they that is low. Consider for the ultrafiltration, PRBC transfusion, and if PeCO2 at 37° low, then pH strategy should be implemented. Special consideration during the RCP, retrograde cerebral perfusion, increase the flow. During DHCA, against SaO2 less than 45%, reperfuse if possible. Evaluate the CMRO2 and consider the management accordingly. Pre-CPB, post-CPB, cath lab. Increase in the depth of sedation or the anesthesia, prevent the hyperthermia. Consider for the mild hypothermia, rule out the or treat the seizures if seizures is there. Assess and treat for the intracranial pathology. And on CPB management, increase the depth of anesthesia, cool further, or consider increase in the duration of cooling. Place the ice on the head and prevent the excessive warming on a CPB end. CPB related kinetics of the SCO2. SCO2 decreases with the arterial desaturation and hemodynamic instability, cardiac manipulation, and caval cannulation. CPB temperature, flow rate, hematocrit influence the SCO2. Mechanical obstruction secondary to the cannula malposition and inadequate pump flow or the pressure were the two most common etiology of the intraoperative cerebral desaturation necessitating intervention. The role of Nirs in the prompt recognition and correlation of the regional tissue of desaturation as a result of aortic cannula malposition or inadequate cerebral venous drainage has since been described in a number of case reports. Moderate hypothermia increases the SCO2 70% to 80%. Deep hypothermia more than 85% to 90%. After about 35 to 40 minutes of the arrest, during the circulatory arrest, SCO2 decrease in a curvilinear fashion to reach the nadir 60 to 70% below the parent pre-arrest value. With recirculation, SCVO2 rapidly returns to pre-arrest values. High SCO2 values are achieved during the regional cerebral perfusion because values on the left may be lower with the regional cerebral perfusion via the innominate artery. It is important to monitor both cerebral hemispheres. SCVO2 decreases during the preoperative period in neonates with hypoplastic left heart syndrome and transposition of the great arteries along with the increased cerebral oxygen extraction without a corresponding increase in the cerebral blood flow. Postoperative SCVO2 vary widely as per physiological variables influencing cerebral oxygen delivery and consumption. With repair of complex lesion in neonates, SCVO2 can decrease when the cardiac output reaches at its nadir at 9 to 12 hours postoperatively. Multi-site Nirs, placement of the Nirs sensor over somatic sites like kidney, skeletal muscle, intestine, liver in addition to the brain, reflex responses to decreasing cardiac output initially produces a decrease in somatic perfusion and thereby STO2 permitting earlier diagnosis and intervention. The somatic cerebral saturation difference, that is STO2 to SCO2, typically is 10% to 20% in healthy infants but decreases towards 0% or become a negative value in low cardiac output state with the redistribution of the limited systemic blood flow and sparing of the cerebral circulation. Cerebral and somatic nerves outcome. Studies evaluating the role of the multi-site and the somatic nerves in a neonate with the HLHs undergoing stage 1 palliation suggest the changes in the cerebral and the somatic nerves in first 6 post-operative hours are predictive of the early mortality and need for the extracorporeal membrane oxygenation. In the first 48 post-operative hours, the somatic cerebral difference of less than 10% was associated with the increased probability of biochemical shock, whereas a difference of 0% or less with an increased risk of the mortality. Renal oximetry and acute kidney injury studies shows mixed findings. There may suggest some beneficial effect, there may not correlate with the mortality, but there are various research showing the mixed results. Regional splanchnic tissue oxygenation also is an area of the interest in the CHD population and may be especially useful given the elevated risk of the necrotizing enterocolitis in neonates with the HLHS or other single ventricle variants, truncus arteriosus or low cardiac output state of any condition. Abdominal SpO2 has been found to correlate significantly with the SpO2, serum lactate and intramucosal gastric pH. Tissue oxygen saturation from sensor placed over the liver did not correlate with the hepatic vein oxygen saturation measured during the cardiac catheterization. However, it could be used as a trend monitor of the SVO2 and the DSVO2. So, trend may be beneficial, but real time may not be having much correlation. NIRS during the ECMO. NIRS could be useful in monitoring the global perfusion and oxygenation of the patients on the ECMO and thus help avoiding the neurological complication of the ECMO. ECMO is typically used to support the patients with the severe circulatory and the respiratory failure. Here in ECMO, several meta-analyses have shown that ECMO therapy can be associated with the significant neurological complications with the incidence up to the 13.3%. Nurse monitoring can be employed to assess both the cerebral as well as the peripheral circulation and thus detect the complications of regarding the vascular cannulation, impaired flow, air embolism, Harlequin syndrome, etc. Nurse assisted monitoring during the ECMO may also help adjusting concurrent vasopressors and inotrope use even in helping the weaning from the ECMO. Nurse will help in ECMO also while weaning part. And observational study by Wong et al. In around 20 ECMO patients mentioned that nurse monitoring was crucial in detecting the complications of the impaired cerebral perfusion and prompt hemodynamic intervention based on nurse value gave the beneficial effect on the patients. An observational cohort study of the Megan F. Hunt et al. On the 39 patients receiving VA ECMO found that the reduction in the RSO2 below 25% from the baseline on the nurse was associated with sensitivity of 86% to predict the acute brain injury. Yesterday et al. Concluded a review on nurse with VA ECMO and made the several significant observations. A drop in RSO2 on the VA ECMO patients or to less than 40% or 25% less than the baseline value where when it is intervened by the various modalities like increasing the flow, oxygen supply, transfusing the blood, checking the shunts, depth of anesthesia, etc. can help reducing the further brain injury. And the front cerebral desaturation may be observed. There is a retrograde blood flow from the aorta to the left hemisphere and the right hemisphere is ischemic. In such cases, strategies like increasing the oxygen flow, improving the cerebral venous drainage or an extra arterial cannula into the jugular vein may help. Patients with the peripheral ECMO with the femoral cannulation have a high risk for the distal lower limb hypoperfusion. The use of the peripheral nerves in this situation can be beneficial to detect early signs of the ischemia by assessing changes in the deoxyhemoglobin and the oxyhemoglobin level. Retrospective pilot study was conducted by the Kilian Payton, and they observed in 2018 on 25 patients receiving femoral VA ECMO and detected that patients with the tissue Nirs saturation less than the 50% or more than for more than 5 minutes was associated with low volume hypoperfusion as detected by the Doppler. A prompt adjustment on cannula based on these parameters will help in avert further limb injury prevention. A retrospective analysis in 490 patients on the femoral VA ECMO by Elias et al. Also suggested that the use of the peripheral nerves to monitor the STO2 reduces the incidence of the ischemic limb. Use in interventricular assist device. Here, other mechanical circulatory system apart from the ECMO like LVAD could also employ monitoring with the nurse to assess the cerebral as well as the regional blood flow. Yasted again et al. Have found here in conducted the observational studies on patients with the left ventricular assist device using in nurse monitoring for both cerebral and the limb perfusion and have appreciated benefits. Prospective randomized controlled studies are still lacking on this perioperative use of the nurse monitoring during the any LVAD or RVAD implantation procedures. Emerging and future application, cerebral autoregulation. For these, moving correlation between the SCO2 or total hemoglobin and arterial blood pressure are used to derive the cerebral oximetry index and the hemoglobin volume index respectively. When cerebral autoregulation is intact, there is a poor correlation close to zero or the negative between the perfusion pressure and the cerebral blood flow, and when autoregulation is lost, the correlation approach to the +1. Impaired autoregulation were associated with the increased level of the brain injury. Functional nerves in the neuroscience. Oligochannel functional nerves is adequate for estimating the global cerebral function, for the evaluating cerebral oxygenation and autoregulation in patients with the stroke and traumatic brain injury. Multi-channel nerves has improved the spatial resolution for the brain mapping, language mapping, etc. Advances in the signal processing max clinical use for detecting certain types of the seizures, assessing autonomic function and cortical spreading depression. High density Hall head optot arrays, precise sensor location relative to the head, anatomical co-registration, short distance channels, and the multidimensional signal processing have improved the sensitivity to the robust assessment of the brain function. The absorption of the infrared light as a function of the wavelength is different for these two chromophores, with the deoxyhemoglobin absorbing more strongly below 790 nanometer and oxyhemoglobin more strongly absorbed at the above the 790 nanometer wavelength. Another is the language mapping. Sophisticated high cortical function and the most important functional domain to localize during brain surgeries for tumor resection and epilepsy. These are inevitable in patients with the bilateral or the equivocal language representation for in the functional MRI. NIRS is a non-invasive alternative test for this. Functional MRI invasive mapping such as the direct cortical stimulation and VADA, intracortical sodium embebital testing. These are the things which can be used as advanced technology. NIRS will work as an alternative for these also, and is a non-invasive tool. Neurocritical care, functional NIRS has the potential to monitor cerebral hemodynamic changes and cerebral autoregulation in the subacute phase of the stroke. Early trial revealed that the hypercapnia induced increase in the regional cerebral blood flow was impaired in the hemisphere affected by the ischemic stroke. In case of the epilepsy, increased cerebral blood flow and oxygenation corresponding to the epileptic spikes and high frequency oscillation can be detected by the functional NIRS. In focal seizure, consistent increase in the oxygenation on the epileptic hemisphere relative to the non-epileptic hemisphere in patients with the temporal and the extratemporal lobe epilepsies. In generalized epilepsies and the secondary generalized seizures, regional frontal oxygenation has been shown to decrease during the seizures. Multi-channel functional nurse devices. Multi-channel functional nurse devices is aimed to increase the spatial resolution. Differential increase in the regional oxygenation or the blood flow has been noted at focal seizures. Autonomic function. For this function, again the functional NIRS can be utilized as a tool to assess autonomic function and dysfunction and postural orthostatic tachycardia syndrome, that is POTS. Patients showed a higher degree of the venous pooling, increased amount of the total hemoglobin in the lower extremities during the 70-degree tilting. Responding time to the oxyhemoglobin and deoxyhemoglobin was faster in the healthy subject than the POTS group, which suggests both neural reflexes and the vascular compliances play roles in this group. Roles of the NRS to investigate the cerebral hemodynamic dysregulation in patients with the dysautonomia, orthostatic intolerance and the vasovagal syncope. Decreased temporal regional cerebral saturation. There are so many uses of the advanced uses of the functional nurse in such type of the situation. There still research are going on, so next few years we can get more information. In the migraine and mild cognitive impairment, that is MCI, application of the functional nerves to detection of the cortical spreading depression and the decrease in the regional cerebral blood flow in the migraine. Potential of the functional nerves as a diagnostic biomarker is further illustrated in mild cognitive impairment like other non-invasive neuroimaging modalities. The functional nerves has been evoked as a potential biomarker to differentiate MCI and the Alzheimer's disease. More research is needed to validate these roles. Recent advance in the design strategies towards the variable nerves. The traditional design with the rigid printed circuit boards PCB with hard electrical components not suitable for long-term wearing. So for long-term wearing, when we plan for using these in different scenarios, we need to do some changes, and these changes has been done, like and growing focus on the softness, miniaturization and intelligence. Extensive research has been done focusing on the constructing variable facilitating the comfort, variable health monitoring and diagnosis, soft lightweighted and variable electronic devices. Quantitative monitoring of the concentration of the oxyhemoglobin, reduced hemoglobin and total hemoglobin, that is total is equal to the oxyhemoglobin and plus the reduced hemoglobin. These parameters provide insight into the blood perfusion for the cerebral, muscle and the cardiac monitoring, making NIRS an attractive technology in both the diagnostic and preventive health care. Here in this picture, you can see three strategies towards constructing variable soft miniaturizing NIRS devices. The outer circle, here you can see either it make the device flexible for hybrid electronics, or there is modular device design. These devices integrating the multiple sensors. And module is prepared for this, and other is the variation in the material. There are various types of the materials which are flexible, can be utilized for this purpose. Here you can see the variable NIRS devices based on the modular device design. 4-channel hybrid 5 EMG NIRS system for the simultaneous acquisition of the muscle physiological, hemodynamic and the oxidative metabolic information. In the A, you can see the prototype of the system. B, placement of the sensors on 4 different positions over the forearm. A multi-channel compact size wireless hybrid surface electromyography that is SEMG, nerve system to simultaneously acquire the muscle electrophysiological, hemodynamic and the oxidative metabolic information. The system consists of the 4 NERS modules and can be employed on 4 different position on the forearm. Here you can see on the forearm position. Hybrid system provide multimodal information about the muscle activation, including the electrophysiologic, hemodynamics and the oxidative metabolism to reveal fatigue mechanism in arm amputated patients. So there are various very beneficial effect of NERS in the societies. Here in the figure you can see the gesture sensing bracelet made of 14 sensing modules. D2E shows the fiberless multi-channel functional NERS EEG system forming a high density optical array for brain activity monitoring. D showing the photo of the NERS EEG cape and E showing the configuration of the functional NERS optodes and the EEG electrodes. NERS sensing bracelet consisting of 14 modules that can be placed around the wrist for the high accuracy hand gestures recognition. Even module of the bracelet contains a light source. So every module of the bracelet contains light source and the detector placed in the rubber holes, facilitating the stretching and the bending of the bracelet. So these are the figures. Here you can see your dual hexagon and the tri-hexagon of the LUMO module for a sensory motor imaging, which enables a flexible NIRS array to construct 3-dimensional image of the target object. Here is a triple hexagon configuration, NERS sensing cape for the infant cerebral monitoring using the 12 LUMO modules. On the same LUMO module, Frija et al. Built a NERS sensing cap for infant cerebral monitoring using this neoprene constructing high friction rubberized surface. 12 dependent LUMO modules located in 2 halves of the cap and connected by the straps facilitate a smooth fit for the different head size and shapes. Here there are various models for the flexible hybrid devices with single sources. Here again flexible hybrid devices with multiple sources. Wearable NIRS devices with the material innovation. There are different types of the material utilized for this and which are having less irritability. Flex material is soft, so it is easy to wear and prolonged period of the time if it is remain in the contact, it will not much disturb the patient. So there are various innovation has been done. Coming to the future development for the direction, the advancement in the human machine interface HMI, the improvement in power source and delivery and the construction of the body area network bands, the integration of the NERS with the other neuromonitoring technologies such as the functional magnetic resonance imaging fMRI, positron emission tomography, that is PET, and the magnetoencephalography, that is MEG-MAG, allows the multimodal monitoring of the physiological states of and the process. One promising alternative is fully integrated or the hybrid system based on the complementary metal oxide semiconductor, that is CMOS microchips. Wearable NERS also has huge application potential in advanced HMIS. Its ability to reveal the brain activities in different cerebral cortex region may enable mind reading to control the machines, haptic devices and robots without physical motions. NERS signals from local cortical activation can assist the control of robotic mechanical hand orthosis for post-stroke hand recovery and rehabilitation. And the last is that together with the EEG and EMG and NERS integrated HMI can realize the control of the lower limb rehabilitation, training robot to help patients with the central nervous system injury do walking training without the therapist. So there are so many innovative our research are going on, and new modalities of the nurse coming which will help in the better care of the humankind. Thank you.